It gives me great pleasure to introduce to you tonight Dr. Tony Goldstone, who's going to speak to us on how we understand hyperphagia. Tony is a clinical senior lecturer and head of the Psychoneuroendocrinology Research Group in the Division of Psychiatry in the Department of Brain Sciences at the Imperial College in London. He attended medical school in Cambridge and Oxford unis and works clinically as an adult consultant endocrinologist at Imperial College Healthcare, National Health Trust, London. He's a fellow of the Obesity Society. He has researched and published widely on neuroendocrine and metabolic abnormalities in Prader-Willi syndrome, particularly investigating the causes of hyperphagia and obesity. His current experimental medicine research uses multimodal phenotyping, including functioning neuroimaging, to examine body-brain interactions in the regulation of eating and addictive behaviours. He runs a specialist adult clinic for genetic obesity, including Prader-Willi syndrome. He's also the scientific co-chair of the first International Hyperphagia Conference in 2009 and has been a member of the scientific committee of the second PWS expert meeting in Toulouse, France in 2006. He's attended several PWS conferences and the PWS expert meeting in France in 2014 and has been a member of the Scientific Advisory Board Foundation of PWS Research since 2014. Thank you, Tony.
Thanks. So a little bit of a whistle-stop tour of concepts around hyperphagia. Just I have some disclosures, which is actually very nice because actually most of these disclosures are drug companies that are now trying to develop drugs for Prader-Willi syndrome. If I'd shown this a few years ago, there wouldn't have been any, but actually that's been a really exciting development in the last few years that a lot of drug companies are now interested in Prader-Willi syndrome. So what we're going to try and cover today is a bit of an understanding of the nature of hyperphagia and overeating, and also trying to understand some of the potential mechanisms, because that may give us some clues to potential treatments. In the absence currently of a good drug, although maybe that may be changing, an understanding of how important it is to control the food environment. And I'm going to give a couple of case histories from my clinic demonstrating that. And then, because I think we're in a potentially over the next few years some exciting times with a lot of drug trials, just give you a current update about drugs that have failed, unfortunately, of which there are many, ones that are showing some interest, and then potentially some ones for the future. So when we talk about hyperphagia, most of us may think about eating large quantities. So this is a very old study now where you present people with Prader-Willi syndrome on the right, or obese controls with a bunch of sandwiches, and say eat as much as you want, and you can see that on average the people with Prader-Willi syndrome were eating 50 sandwich quarters, which is about 25 slices of bread in an hour. Whereas the obese controllers were eating a fraction of that. What's I think important to realize is that actually there's a huge variability in the people with Prader-Willi syndrome. So the one at the top had eaten 100 and the one at the bottom had only eaten 10. So I think that's interesting. We don't really yet understand what that variability in the food consumption is. But this is not what I would call classically hyperphagia. This is eating too much. And obviously in this extreme end of the spectrum, it is obviously going into the hyperphagia territory. But hyperphagia is much more than just volume of food eaten when given the opportunity. And there's a number of questionnaires originally developed by Elizabeth Dykins from Vanderbilt, and more recently adapted into the hyperphagia questionnaire for clinical trials, which is quite useful in a clinical situation. It also becomes often the primary outcome in many drug trials. So it's about being upset when denied food, bargaining or manipulating to get more food, even eating food out the trash, sometimes even rotten food, and rarely, but it does occur, even non-food items as well. Getting up at night to food seek, being very persistent in asking and trying to get food, being sort of obsessed about food and spending a lot of time talking about food, trying to sneak or steal food or money to buy food, and getting very distressed when others try to stop them asking about food or obtaining food. And it's these sort of tantrums that emerge around that that are obviously very disabling and affect family life a great deal. And all this preoccupation with food sort of interferes with the ability to live a normal, independent life. So you can see that hyperphagia is very much more than just a volume of food eaten and being hungry. It's much more than that. We have become aware that the development of hyperphagia is a bit more complex than originally thought. Originally, it was thought that people with prader-willi syndrome, when they were babies, didn't feed very well, and then they switched to hyperphagia. But actually, it's now apparent that there's a rather more complex development, and that after this initial difficulty feeding relating to neonatal hypertonia, there's then a period where they actually may have no difficulty feeding and grow along growth curves. Then there's a beginning of an increase in weight without increasing caloric intake. And then the calories begin to be increasing, then the hyperphagia develops. And maybe, as we discussed earlier, as people are getting into older adults, maybe there's a few in which the hyperphagia becomes much less. And we still do not understand why there is this slow development of hyperphagia in pretty well every other hyperphagic genetic condition associated with early onset obesity. The hyperphagia is there from very early age, even under a year, whereas in prader-willi syndrome it's much later. And what we did with Tony Holland, found that this cutoff in the BMI increasing above normal, it was about 33 months, and the hyperphagia from questionnaires sort of kicked in at about 40 months. So, it's a little bit later than the original development of obesity. Early diagnosis is vital in putting in a structure around low-calorie, well-balanced diet with appropriate counselling of the family, and instilling the fact that although early on it may not be present, it is likely to develop later. And then there needs to be a rigorous supervision and control of the food environment, with access to food and money restricted during childhood. And then the difficulties come when adulthood and independence is sought in many people with PWS, and then we have conflicts and difficulties. Exercise is very important. People with prader-willi syndrome are very sensitive to exercise in terms of weight gain. During lockdown, some patients have gained weight because they haven't been able to even go out on their daily walks, and so that's important. Our mainstay of some of our therapies now, like growth hormone replacement, which helps body composition, does not have the effect on hyperphagia, and that's important to realize. I'll go into a bit detail in a moment, but none of the previously licensed anorexigenic agents have been successful, or if they were, they had side effects. There are several trials that are ongoing and are producing some suggestive possibilities, and so we hope that we may have some drugs available in the near future. Bariatric surgery is generally not recommended by the community of people with PWS. The complications seem to be quite large, and there is still a paucity of long-term data, although, as I'll show later, one group does claim that some surgery works, but by and large, since we feel with this control of the food environment we can achieve some successes, that at the moment we do not recommend it. So this just demonstrates the benefits of controlling the environment. These are a couple of patients in my clinic. So this is a 25-year-old patient, been diabetic since the age of 19, in the family home, progressively gaining weight up to a BMI of 60, then moved into a specialist residential home, lost fantastic amounts of weight over 2 or 3 years, went into the specialist residential home on 4 to 5 medicines for diabetes, with large amounts of insulin, 140 units per day, and a not very controlled sugar level with an HbA1c of 100. And within a couple of years was down to just one medicine, and that was metformin, normal sugar control off insulin. And in fact, in this period, was having very low blood sugars, hypoglycemic episodes. So the poor diabetes was not just insulin resistance, it was being driven by very large amounts of caloric intake. Another patient demonstrating the effects of physical activity, not doing well in the family home, gaining large amounts of weight, family unable to cope, moves into a specialist residential home, progressively lost weight over the years, goes home for a short period, gains weight. Had a problem with a knee, confined to a wheelchair most of the time, gains weight. So that physical activity is a very important thing. Again, sugar control and need for insulin, rapid reductions in average sugar levels and reductions in insulin as they lose weight, and an increase again in the poor sugar control when their physical activity reduces. You don't need to pay attention to the complexity of this slide, but this is just to summarize that there are lots of genes in the Prader-Willi syndrome region. I think you've had a previous session about genetics. And we're still limited by the fact that none of our mouse models of Prader-Willi syndrome, which knock out either the whole region or individual genes in this region, seem to replicate the whole hyperphagic phenotype in Prader-Willi syndrome. As you may know, there are a number of patients, about 4 or 5 now, who have a small microdeletion in this SNORD116 gene cluster, and there is some evidence to suggest that in animal models that can affect some of the hypothalamic anorexigenic pathways that may be vital. And certainly you can get the full Prader-Willi syndrome phenotype in people who just have lost this gene, and you don't tend to get that in people who've lost other genes in humans through small deletions. So this SNORD116 cluster seems to be very important, and it seems to affect the processing of a number of different downstream genes, which may then affect the presence of a number of hypothalamic and maybe other neuropeptides throughout the brain. One particular effect of these gene loss is an absence of oxytocin neurons in the hypothalamus. This is post-mortem people with Prader-Willi syndrome, so a reduction in the number of oxytocin neurons compared to controls, and that's also seen in some mouse models. Oxytocin not only alters behavior, but also suppresses appetite, but replacing oxytocin doesn't seem to have a huge effect on appetite, although there may be some effect, and that's being done in trials. So we know a lot more about the pathways that affect appetite in humans and also in animals, and there's a number of patients who have gene mutations within these pathways, from the hormone leptin from fat acting on the leptin receptor, then in the hypothalamus acting on the POMC neurons that produce alpha MSH that reduces appetite, that acts on the MC4R receptor in second downstream neurons that suppress appetite. Many of those neurons are within the paraventricular nucleus. If you have a gene that affects the development of the paraventricular nucleus called STIM1, you get a very Prader-Willi syndrome-like phenotype. And there are other genes that affect the processing of this gene and the product, the peptide products, as well as a number of other peptides. And for example, we have a patient who has a CBE, carboxylase E mutation, who again has a very identical syndrome to Prader-Willi, which I'll come on to later. And that has led to the development of potential targets within this pathway, and that's particularly within this MC4R pathway. And these neurons within the hypothalamus act on downstream circuits through the MC4R receptor to inhibit appetite. And there's now an agonist for this MC4R receptor that reduces appetite. It's been very effective in people who lack POMC, who are lacking alpha MSH, and who lack the leptin receptor that basically stimulates these neurons. But unfortunately, a trial in Prader-Willi syndrome was not effective, unfortunately. It's also important to realize that the abnormalities in Prader-Willi syndrome are not just the hypothalamus, it's the whole brain. It's just a number of studies showing abnormalities, a nice review from Tony Holland, summarizing that. So it's not just the hypothalamus. We don't quite know how these other cortical abnormalities may contribute to hyperphagia, but they're potentially likely to be playing a role. There are a lot of peripheral signals that affect appetite, these ones inhibiting appetite and ghrelin increasing. In Prader-Willi syndrome, there's evidence of reduced production of pancreatic polypeptide from the pancreas, a anorexigenic peptide, and high levels of ghrelin, an orexigenic peptide that stimulates appetite. This isn't really likely to be effective because the effect size is probably quite small of pancreatic polypeptide. And here are the very high ghrelin levels, both fasting and even after a meal, compared to obesity, where ghrelin is usually reduced. And it's thought that this might be contributing to hyperphagia. It's certainly not, but it has to have this octanyl group shoved on the third amino acid through an enzyme called GOAT. So this is inactive unacylated ghrelin, and this is acylated ghrelin. And some studies have suggested that the switch from the lack of hyperphagia to the hyperphagia that occurs between the phases may be because of an alteration in this ratio of acyl to unacyl ghrelin, so that early on there's a relative deficiency of this, as the hyperphagia develops, there's a deficiency of this unacylated ghrelin that may counteract the active ghrelin. And this led to a trial of an analog of unacylated ghrelin, which in a small trial reduced hyperphagia questionnaire scores. But unfortunately, a subsequent study that took place over 3 months with this drug, levolotide, showed no effect on hyperphagia. And unfortunately, the drug has now been stopped being developed as a treatment. The GLP1 analogs, this is another gut hormone that's used to treat diabetes because it stimulates insulin secretion in the pancreas, but also is a satiety hormone in the brain. Has been used by many people for people with diabetes in Prader-Willi syndrome. It does improve diabetes, but not in my experience much effect on appetite. There's just finished a Novo Nordisk trial of the higher dose of the GLP1 analog liraglutide for people with Prader-Willi syndrome, which we'll be reporting soon to see whether there's any benefit of that. I'm afraid I can't give you the result yet because it's not in the public domain. There have been some drugs that have been effective, and it just shows you that, you know, the skepticism about drugs not working may not be appropriate. So beluranib was really the first medicine about 4 years ago that was tried. It's a drug that was thought to act on fat cells to alter fat oxidation, but it was having more effects because although it had dramatic effects of weight loss, we're talking about, you know, 8 to 10 kilogram weight loss compared to placebo over 6 months. It also reduced hyperphagia, and so maybe it either altered the secretion of something from fat cells or had some brain action. But unfortunately, it has a completely unexpected complication, deep venous thrombosis and pulmonary emboli, and unfortunately 2 patients passed away from pulmonary emboli, and so the drug has had to be withdrawn. They've tried to develop a second line agent similar, but unfortunately have not been able to find one that's yet been safe. So red is our drugs that have failed. We've beluranib failed, levolotide failed, setmelanotide, the MC4 agonist, failed. Rimonabant, the endocannabinoid cannabis receptor antagonist that blocks the cannabis munches, may have had some effect, but in Prader-Willi syndrome, 50% of the people develop psychiatric side effects, and in the general population, it got withdrawn. Inhibiting the enzyme that converts inactive ghrelin to active ghrelin, they had a very effective drug that did that, but unfortunately had no effect on hyperphagia or weight in Prader-Willi syndrome. Oxytocin and oxytocin analogs may have a little bit of an effect for appetite, but seem to have a greater effect in children in terms of preventing anorexia and maybe helping failure to thrive. And so that's where most of the target of therapy is. Diazoxide is a very interesting drug that seems to be altering the activity of those NPY orexigenic and POMC anorexigenic neurons in the hypothalamus, and we've had some trials that show some potential success, and there's an extended trial, open label extension going on at the moment. As I said, we wait to hear about liraglutide. We had a number of other drugs that were targeting feeding pathways in the brain, which were never really tried in Prader-Willi syndrome, and unfortunately have now been withdrawn in the general community because of unacceptable side effects targeting different pathways, and so are probably not ever going to be tried in Prader-Willi syndrome as a result. And this is just the original study for the diazoxide, showing quite marked reductions in hyperphagia questionnaires and reductions in body weight as well. And as I said, there's a extent studies going on. So in the future, what have we potentially got? So Levo are developing a drug trial, hopefully, that will hopefully improve, and I'll come on to why in a moment, an enzyme in the brain called prohormone convertase 1, which I'll show you in a moment may have a lot of potential effect. Pitolisant is a histamine receptor antagonist that may reduce appetite. Tosomet is a complicated drug that prevents the reuptake in a variety of monoamines, which may have an anorexigenic effect, but because that can have a side effect of causing increased heart rate and blood pressure, they add in a beta blocker to suppress that. Cannabidiol, part of the cannabis plant, but not the THC that causes the acute psychiatric effects, and may have a multiple actions within the brain, maybe being developed as a pathway. Companies interested in developing a ghrelin receptor antagonist, but given that the goat inhibitor didn't work, I'm not convinced that they may not necessarily be effective. And there's now some newer GLP1 analogs, which in the general obesity population are having huge effects. We're talking averages of 20% weight loss. So depending on what the results of liraglutide shows, it will be interesting to see whether a more potent GLP1 analog may have an effect. Although at the moment, I don't believe Novo Nordisk are planning any trials in Prader-Willi syndrome. So why does this PC1 enzyme be important? So people who have genetic defects in this pro-hormone convertase 1 develop obesity. And as I said, we have a patient with a carboxypeptidase E mutation, which is a similar enzyme. And these are basically enzymes that alter the processing of pre-peptides, so that's pro-hormones, to their active hormones. And it's been found in animals and in cells that are missing this SNORD116 gene in Prader-Willi syndrome, that at least in some studies, but not every study, there seems to be a downregulation of this pro-hormone convertase 1, which may be affecting the production of mature peptides in a huge number of systems within the brain, which may contribute to some of the phenotypes. So if a drug could be found that can increase PC1, there may be a way of, very early on in the post-genetic pathway, correct things. And there may be some developments there. As I said, bariatric surgery, there's lots of different types. Reviewing of the literature shows, for example, in gastric bypass procedures, large amounts of complications, although it must be admitted that many of these papers were early on and things are a little bit better now in terms of safety. But several of them also regained weight after several years. And you can look at the weight regain compared to non-Prader-Willi patients. The weight regain over, the weight loss was much reduced. One group in the Middle East claims that sleeve gastrectomy is effective and they follow people up. But again, it's still only been a follow-up of a few years. And in the general non-Prader-Willi community, there is quite a lot of weight regain over the years. And there isn't really the data at the moment to be able to justify doing this.